Good afternoon, everybody. Thank you very much for the invitation to participate in this event. I presented 2 years ago. I think we are bigger now. And I'm always happy to be in Canada. I lived in Canada for 4 years before moving to the United States. So, a couple of disclaimers. I'm an employee of GE Healthcare full-time, and we'll talk about adaptation of theranostics, which involves changing potentially activities and doses, but to be clear, we are not promoting by any means off-label use of the drugs, just getting ready for the future. So we are a technology provider, like other companies, and we have a large footprint in our space here, theranostics, and a lot of interest in the development of this field. In our view, technology is very critical, and we developed great technologies in the recent past. I will not make a commercial presentation, but I do encourage you to look at our Omni PET-CT platform, fully scalable from entry level to total body, our ultra-fast SPECT code StarGuide. But the topic for today will focus more on the digital side, not about having multiple technologies in isolation, but resonating much with what Dr. Wong presented earlier. How do we connect the care pathway? So that's something we are paying a lot of attention because we are following the trends in this market, and that's where we believe we should invest in technology. So on the trends, I'll show you 4 of them. Very simple slide, simple language. This is for all audiences, including experts and non-experts. But you will see that we try to, in a simple way, understand what's the impact for our customers, for the users, for the field. So the first trend is PSMA therapies used earlier in the process. That's a major one. The Pluvicto label has already been expanded in the United States for castration-resistant prostate cancer, pre-taxane. The next step, if it happens, most likely it will be using PSMA therapy in the hormone-sensitive setting. This changes a lot. We go to meetings and we know that the decision-making process is much more consequential and much more complex because there are many options to treat the patients will live longer, concerns with toxicity are escalating because of that. So there will be impact in the way our customers and physician practitioners use it. The second trend is combination therapies. Most of the trials today are not monotherapy. We're trying to combine lutetium PSMA and others with chemo, PARP inhibitors, immune checkpoint inhibitors, and a major one, combining radioligand therapy with radiation therapy. There are many trials, and this is already happening in clinical practice. So this is also going to change the dynamic and require more interdisciplinary collaboration. Third trend, new indications. I personally thought it was going to slow down a little bit, but year after year, the number of trials and targets is increasing. There's no plateau yet. So centers that want to do clinical trials, there will be a lot of them for the foreseeable future, So that also increases the need for more flexible protocols, more ways to manage the department with more flexibility. And finally, a trend that we see a lot in the United States, I'm very tracking it very closely in other regions, which is decentralization. Because after you figure out radiation safety aspects, the infusion itself, it's not high risk. We don't need hospital infrastructure around the patient during the infusion. So many small clinics are installing infusion beds and doing theranostics. 60%, according to Novartis official data, 60 plus, is already delivered close to home for many patients in the US. This is going to compete with the trend of more complex decisions. We believe that there will be a need to centralize the decision-making process, but decentralize the services, the therapies themselves. That's what I would like, knowing what I know. If I'm treating a relative, my father, or actually I'm getting of age myself, I would like a center that has the best decision makers thinking about what to do with me, perhaps in the academic side. But I would love the convenience of getting the therapy close to where I live, or the labs, or the imaging as well. So this decentralization, we believe, is going to be the norm, and that requires also more coordination, more interdisciplinary and care coordination. So all of these, you can see a common denominator, not only in growth, but also in complexity and the need for coordinated care. Now, one more major trend is what I would call adaptation of the protocols. And we are branding a new terminology here. Theranostics, as you know, can be a miracle for the super responders, but the average overall survival is still not showing very exciting results. It's just a regular oncology drug used towards the late stage. So the VISION trial, most of you know, it has an overall survival increase of only 4 months compared to standard of care. Interestingly, the recent trials are kind of following the same pattern. So how, besides all the problems that we know of, supply chains, skilled workforce, and all of that, from an industry mindset, if we can make theranostics better, if it improves survival, many things will fall into place, because we'll have a better offer, a better product, if I may put it this way, to offer society. So that's a major priority for us, how to enable more survival. And we believe there are 3 pathways to improve survival. One, new drugs. I don't mind the number of trials. This is a little outdated, but last year we filtered 80 or so trials looking at new molecules, 20 or so. New approaches, meaning new combinations, and the third one is adapting the protocols. This is something we highly expect in theranostics, that we will be able to dynamically adjust what we are doing cycle after cycle, and this is one of the ways theranostics is going to be more effective. So we would like to enable that. How can we, as technology providers, enable? First, let's define it. Okay, so Dr. Wong, I'm going to change this to transdisciplinary, but for now I'm using the old nomenclature. I had not watched your lecture before. So, a closed-loop system. It's not only about dosimetry. Dosimetry is part of this equation. Adaptive theranostics, it is about how to start and how to dynamically adjust. What's the best approach to start? Is it a monotherapy or combination therapy? Some of these are not on label yet, and we just want to be ready for when it happens. And then how to adjust along the way. Look that I highlighted the word multidisciplinary in the definition. In our view, a center of excellence, it will rely not only on technology, on fancy clinical trials, but the #1 source of strength and success is interdisciplinary, transdisciplinary collaboration. And definitely something we would like to enable with technology. So, these for us are 2 pillars. You need 2 things to enable this future. #1, tools that are very flexible and very powerful to manipulate and quantify images. So we acquired a company called MIM Software. Most of you that are in the field know this company. Is very flexible. They have 3,000 or so users around the world and are now part of our family now. And the latest technology that we had just developed and we are bringing to market this year is called IRT for theranostics. IRT was developed for radiation therapy. It stands for Intelligent Radiation Therapy, and we developed a module specific for theranostics now. This tool is going to do the orchestration. Initially, workflow orchestration, and later, more and more, care orchestration. It will be a tool that will be a window into the patient for all the stakeholders in the value chain. So quantitation and orchestration are the two pillars, in our view, to enable adaptive theranostics in the future. This is a couple of examples. So dashboards with all the patients undergoing radioligand therapies in the department, smart scheduling, and beyond that also summarization, clinical data, clinical information. So for all stakeholders, information will be readily available and will be able to circulate and flow across different locations, different specialties, and in different time points. So just to go further as we envision the future, this seamless integration of the care pathway for us is going to be the key ingredient for us and for practitioners of theranostics. And artificial intelligence will need a platform to be deployed. And this is where we are doing. What I'm showing now is just a vision. Some of these are projects, some of these are just concepts for now. But we do envision LLMs for summarization and to consolidate information for the reading experts and for the therapy experts as well. Predictive models will be essential to support decisions about what will be the best approach for an individual. Agentic AI will more and more help the workflow steps. Predictive models also for the post-therapy to make dosimetry more accurate, for example, or more actionable after we measure the SPECT-CT, and then for surveillance as well. So the vision is adaptive theranostics. We will not even need the terminology. It will be part of the definition. We're just making a strong statement about that. Will be enabled by quantitation and orchestration, and will be the platform to deploy artificial intelligence in our field. Thank you very much.